Welcome to Part 4, Non-Intentional Childhood Injuries. This part is going to address burns. I do want to mention that Chapter 34 has the emergency management of injuries in children. So make sure that you look over that as a supplement to the video lectures. There are a variety of types of burns that any of us can sustain. We have our thermal burns, which are going to be things like flash burns, where something just quickly has a quick spark, super hot flame, and then it's over and done. We can have scalds. We can have contact, like in touching a hot light bulb or an iron or a stove plate. We have chemical burns, the lye-based burns, and a variety of household cleaners. We have electrical burns, uncovered outlets, and the kids stick things in and they become a part of the current. Electrical cords, when these little kids are crawling around, they see cords. Oh, that looks so good and it's colorful, and then they bite it. Once again, they become a part of the current. So electrical burns are very interesting in that when I say this child becomes a part of a current, wherever the entry point is for electricity, there is always an exit point. And so if a child is standing up, holds onto an electrical cord, puts it in their mouth, and bites down, we would expect to see burns on the child's mouth, on the lips, on the tongue, maybe the buccal mucosa, but that's where the electricity went in. And electricity tends to go on a straight line, and so we may have an exit wound that is way out the back of the throat, or it can go all the way down the body, and as it goes down the body, of course, the heart is right there, depending on what angle that this child bit, and it can exit out the toe. So any kind of an electrical injury has an entry and an exit wound. We don't always see that exit wound because it just went so far, but it actually fried up some of the other tissue as it went through. We do stage burns. You do need to know how to stage burns, and it is in your textbook. There's a nice example of how do we say the percentage of burns, a child versus an adult, because it's like, well, what's 10%? Well, on a little baby, they're small. So if they have a head burn, that's like maybe 20% of their body. But what you need to know is what is the difference between a first degree, second degree, and third degree. So a first degree, think of it like a sunburn. Many of you have probably had a sunburn where you're out in the sun a little bit too long and you just get red. You don't have blisters, you are red. That's a first degree burn. On our second degree burn, we have partial thickness, and there's two different ways that we can differentiate these, but it's the degree of the blisters and how deep the wound has gone. And then we have full thickness. We've gone all the way through the dermis, and we've even involved the nerves. So which ones are the most painful? Well, when you think about your sunburn, that gets pretty sore. You go to bed at night and you're like, ooh, 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 that hurts. Then you have your second degree burns and you have all these blisters. So you not only had a sunburn, but man, you were out there for way too long, and now you have blisters, and those are hurting even more. So it's actually our first and second degree burns that hurt worse than the third degree, because the third degree actually kills the nerve. It chars tissue. So I have the couple of pictures here that you can stop and just take a look at it. So we will treat first and second degree burns depending on the degree, how much is involved. Generally, we can do that at most acute care facilities, but full thickness third degree burns, we stabilize them and we get them to a burn center because they're going to be in for a long time. And UCI has a burn center. Obtain the history. Find out, how did the kid get burned? What did they get burned on? Do they have an airway? It's not going to do us any good to save this kid's burns when they're not breathing, right? What is their level of consciousness, their neurostatus? Are they irritable and are they restless? Are they in pain? And so remember, first and second degree, there's going to be a lot of pain, and they're not going to want to let you touch it very much. So based on the percentage of the total body surface area that's involved is what's going to determine whether or not we admit the kid. How deep is the injury? The younger than 2-year-old kids have a much higher morbidity and mortality rate. Who wants to do dressing changes on a little baby when they have these burns? And oh, I just couldn't possibly do it at home, my goodness. And then they get infection, sepsis, and then they die. Now, that's really not why they die. They die because they're mainly water, and a greater percentage of their body surface area gets burned. The areas that are involved: hands, feet, perineum, joints. Every place has the possibility to scar. And when you're looking at joints, then contractures can develop because they're not going to be moving it much. So they have permanent injuries. When the kids get burned on the face and on the neck, there's a greater potential that the airway will be compromised. And then they can also have additional injuries. So let's say this was a motor vehicle accident and the car started on fire. Well, we have a head injury from them hitting onto the glass. They also broke their femur and their humerus because they got sideswiped or whatever it is. They can have a lot of other things in addition to the burns. So our urgent evaluation is going to be their blood count, an electrolyte panel. We will do ABGs and eventually a Chem 7 because we want to see what their BUN and creatinine is as well as their glucose. I have listed here your NANDAs that are appropriate. So we have our fluid and electrolyte balance. Very important in a burn. We have a lot of fluid shifting. So when you get crusts on wounds like this, that's all serous fluid that's weeping out of this child. And so that's fluid loss. Decreased cardiac output because they become very tachycardic, especially if they're going into shock and then they're going to lose their pulse. Decrease in the blood flow to the kidney, and so we have compromised perfusion that way. Remember, the kidneys also maintain our blood pressure. Pain, exquisite pain with our second degree burns. So we'll be giving IV morphine for that. We don't anticipate infection to set in until about the 3rd to the 5th day as this tissue is dying off. So we want to keep blisters intact, but so these are our different NANDAs. So at the beginning, it's a potential risk for infection, and then we may have actual infection. Alteration of the gut function, and that is because of the stress response. And so these kids, many kids who have burns that we're keeping in the hospital, we put them on PPI to prevent that. And then the psychosocial, the body image disturbance. Remember, burns leave big scars and they last for a long time. So the greater the percentage on the body, the worse it's going to be. So there's contractures and scar formation. Our priority interventions, I already mentioned, your airway, giving them fluid. So if they have 70% of their body is burned, they already have circulatory collapse, and you're going to have very few areas where you actually can start an IV. So this is an example of where you might see an intraosseous infusion put in at the beginning. Nutrition, they may end up needing an NG tube or a G tube, IV protein, or we're just going to increase the protein in their diet to promote tissue healing. For pain management, definitely IV morphine. When you look over on the right side where I have recovery, we have physical and emotional. Well, part of that physical recovery is going to be physical therapy. These kids might be going down to the whirlpool for wound care. And so you want to pre-medicate them with the morphine because it's going to be painful. We do tetanus prophylaxis in the emergency room, and then we have wound care. So antimicrobials, we use Silvadene, which is a beautiful cream. Comes in a very big jar. It's very smooth, and you use a sterile tongue blade and you put on a healthy layer. The whole thing should be covered white with it. And then when they go down to Whirlpool, all that dead skin is going to come off, and they're going to have raw wounds. And we're going to put more Silvadene on, and then we wrap it with a bulky dressing. We put a non-stick dressing on and then wrap it with Kerlix. And then the debridement, like I said, it's going to be very painful. And they go down every day, some of these kids. So a lot of emotional support. Get Child Life in to be part of the therapy to keep this kid really happy when we're not doing anything. You go in there, play with this kid so that you're not always looking like the bad guy. Are these kids going to be admitted? If over 15% of their body is burned, we tend to admit young children. We will give a fluid resuscitation of lactated or normal saline, and it's going to be the same bolus. And then monitor their urine output. We want them to have at least 1 to 2 mLs per kilo per hour. If they're not making it, then we're going to admit them. So this ends the lecture about burns.